Welcome, and thank you for joining us today for the SPH Analytics webinar, Take Action Now to Maximize 2017 Mips Scores. We will have a question and answer session following our presentation today. Please type any questions you have for our presenters into the Q&A tab of the WebEx portal at any point during the presentation. We will also be recording today's webinar and will make the recording as well as the slide deck available to our attendees following the webinar. Now I'd like to introduce our first speaker, Dr. Bill O'Connor, Chief Medical Officer. Dr. O'Connor has more than 20 years of healthcare experience focused on population health, clinical analytics, operations, product development, strategic planning, and sales. He holds a Doctor of Medicine degree from New York University School of Medicine and has practiced within the area of orthopedic surgery. Dr. O'Connor brings to SPH unique industry insights from his tenure at Orion Health, the leader in HIE within the healthcare market, from McKesson Corporation, PricewaterhouseCoopers, Zinc Health, and Allscripts. Welcome, Dr. O'Connor.
Thanks very much, Terry, and good morning and good afternoon, everyone. Again, my name is Bill O'Connor. I'm the Chief Medical Officer and Executive Vice President of Strategy here at SPH Analytics, and wanted to thank you for joining us this afternoon to be able to hear a presentation and speak to and ask questions of a couple of our industry and product experts. And I think that macro, which drove Mips, is one of the most complicated but one of the most important pieces of legislation that is impacting medicine today. And your Mips score and your organization's Mips score is going to have a significant impact on both your reimbursement, but as well as what are about to be very transparent quality scores. So a really important time in medicine, and it is an area that we decided to focus on here at SPH Analytics. And you can see from the slide that we're very proud of, we received the #1 ranking from Black Book for 2017 for MACRA and MIPS support technology for value-based care. And it's something we've been working really hard on. It's something we're very proud of. And it's really a result of the folks that you'll hear on the phone today and their hard work and their partnering with folks around the industry to be able to understand what MIPS is and how important it is and how to maximize your performance relative to that. So we've got a couple things here at SPH Analytics. One is our MIPS Max program, and not only can we help you with your quality scores related to MIPS, but we've got other areas that we can support to help you maximize your overall score and the other categories within MIPS. We also have a penalty-free guarantee. So through the work that we can do with you, at the very least, even if we get started relatively late, we can guarantee that you won't have a downside for your organization. The downside, depending on how much you're billing to Medicare, can be very significant. So that's something we can partner with you on as well. And my final message before I turn it back over to Terry here to get this going is, it's not too late to get started this year. I know a lot of folks got started earlier and are in a very good position for next year. And some folks were probably driven by some of the uncertainty coming out of the federal government and haven't done much yet. But there's still plenty of time left in this year to get a good program going such that you can drive really good results in 2017 going into 2018. So with that, again, I thank everyone for joining, and I'll turn it back over to Terry.
Thank you, Dr. O'Connor. I'd like to introduce our next speaker, but before I do so, I'd like to remind everyone that we will have a Q&A session following our presentation today, so you can type questions for our presenters into the Q&A tab of the portal at any point during the presentation. Our next speaker is Sara Zywicki. Sara joined SPH Analytics in 2016 as Vice President Clinical Product Management. She leads the product management team in developing new solutions for the population health and quality measure marketplace. Her experience spans nearly 20 years in the healthcare industry. Prior to SPH, she served as the Vice President of Clinical Operations and Product Management at Lifeline Screening and Community Healthcare, and was responsible for driving the expansion of clinical services to Medicare beneficiaries and patients in the 50-plus demographic. She also has a background in medical device marketing and clinical product development. Sara holds a Master's of Public Health and a Master's of Business Administration from Emory University and a Bachelor's in Biology from Northwestern University. Welcome, Sara.
Thanks so much, Terry. And thanks, everybody, for joining us this afternoon. I do just want to echo what Dr. O'Connor had mentioned, that, as we approach mid-year here for the first Mips performance year, we understand that there's still many organizations and many providers that, have not yet developed their strategy in place for maximizing their Mips performance. And so today, we really hope to share some specific strategies and cover really some of the highlights, again, of the regulations on how you can excel in all three of the Mips performance categories, especially quality, since it's weighted the most, and avoid that negative adjustment in 2019, and hopefully even earn a positive adjustment in 2019. So on the first slide here, I just wanted to, again, reiterate out of the quality payment program legislation, we really had three Medicare programs sunset, and these legacy programs were PQRS, value-based modifier, and the EHR incentive program, or meaningful use. And so those have become the three new Mips categories that are weighted for this year, and then the fourth category, cost, which is not weighted this year, but it will be for next year. And so today I wanted to cover really a lot going into how you can optimize that Mips composite score, really being driven by quality performance as well as improvement activities and advancing care information. Oops, excuse me, sorry about that. So one of the most critical things to really take away with the difference between PQRS and Mips is that PQRS was pay for reporting and Mips is pay for performance. So it's very important to understand how you earn the Mips points in each of the categories and how they roll up into the Mips composite score that, again, will be between 0 and 100 points. And so this table really just illustrates that there are two really critical thresholds that CMS will issue every year. One is the performance threshold in which to avoid a negative adjustment. And in this first year, it's 3 points. So 3 points or higher, you're going to be able to avoid the negative payment adjustment of negative 4% in 2019. The second important threshold that CMS will issue every year is the exceptional performance threshold. And for this year, that is a Mips composite score of 70 points or more. That's really allowing you to get eligibility in a completely different pool of funds. And so that allows you to be eligible for exceptional performance. It's funded by a $500 million pool for the initial 6 years of Mips. And so just keep that in mind. This kind of points, every point above the performance threshold, above 3, is going to be in favor, and every point below that performance threshold is going to be, a negative payment adjustment. And so each year we'll be looking for what the performance threshold and what the exceptional performance threshold is. Next year, most likely the performance threshold will not be 3 points. It might not be the mean or median just yet of the Mips composite scores, but surely in 2019, what was stated in the final ruling is that the Secretary will establish the performance threshold to be the mean or median of the Mips composite score of all providers. So that's why it's really important to get a head start and have a good understanding of where your total Mips composite score will fall in these first couple of transition years. All right, so I wanted to just spend some time highlighting the largest weighted category of Mips, and of course that's the quality category, and just point out again some of these differences between PQRS and Mips quality. So with PQRS in the past, there was 9 measures across 3 domains, and 1 had to be cross-cutting, and that's very different this year. You choose 6 measures from a list of 271 eligible measures, and 1 has to at least be an outcome measure. If you don't have an outcome measure, then you can pick another high priority measure. Now, just keep in mind that you can submit more than 6 measures. CMS will take the top 6 performance, and you'll get scored on the top 6. But if you do submit more than 6 and they are additional outcome or high priority, you can earn those bonus points. And for additional outcome measures, you can earn 2 points, and for additional high priority, you can earn 1 point until they're capped at the 10% of possible points. So that's either 6 or 7 points, depending on the total number of quality measures that you'll have to submit. Also, keep in mind that you can get bonus points for something called end-to-end reporting. That means if you are using data that's coming right out of your CERT, your Certified Electronic Health Record Technology, and it's not being manipulated or manually changed in any way, that you're taking data directly out of CERT and using it for your quality measures, you'll be able to get a bonus point of 1 point for each measure, and that also is capped. So please keep in mind these bonus points can absolutely help you offset poor performance in these first couple of years. So I absolutely encourage you to make sure there are avenues for you to be able to capture and earn the bonus points for end-to-end reporting as well as additional outcome. The other thing to keep in mind is that PQRS in the past was a reporting rate of 50% of your Medicare Part B patients. That's very different in MIPS, and if you're reporting by QCDR or Registry or EHR, your reporting rate's actually 50% of all patients that meet the measure's denominator criteria, regardless of the payer, so Medicare or non-Medicare. And that data completeness threshold, or the reporting rate, whatever you want to call it now, will increase to 60% next year. Now, some of you may be subject to a 7th measure, and that's only if you have sufficient case volume. So there is another measure called all-cause hospital readmission. It's automatically calculated by your Medicare claims, only if your group is greater than 15 clinicians and you have sufficient case volume, 200 cases. So in this situation, you not only have just 6 total possible measures, you have 70 total quality measures for possible quality points of 70 points instead of 60. Another thing to keep in mind is that CAPS for MIPS, which is the patient experience, patient satisfaction survey, or any other type of patient surveys or clinician group CAPS, they count as either a high priority quality measure or high weighted improvement activity, but not both. So previously, PQRS for CAPS for PQRS used to be required if you were a provider organization of 100 or more providers. Now it's optional, but you can be as low as 2 or more eligible clinicians and do a CAPS survey, and you could use that as one of your high priority quality measures or one of your high weighted improvement activities. Just keep in mind that you must register for CAPS for MIPS by the end of this month, June 30th. You don't have to select your vendor until September 19th, but you do have to register for CAPS for MIPS. And then also keep in mind that if you do choose to do CMS web interface, that is only an option for 25 providers or more. It used to be called GPro web interface, now it's called CMS web interface. And if you choose to do that, you report on the full 12 months of data for all 15 CMS web interface quality measures. All right, so just a couple of things to keep in mind about how you earn, improvements in the performance points. And I just show here some of the definitions for how the reporting rate and how the performance rate is calculated. And these both are important because it's important for you to improve on your performance, but it's just as important for you to have proper documentation. And that's why they even have this data completeness reporting rate. The data completeness rate is calculated by taking the performance met plus non-met plus the denominator exceptions over the denominator. And again, you're looking for 50% or greater. And then the performance rate is simply taking that performance met, and it's really taking the performance met over who's met or non-met, because it's the data completeness numerator minus the denominator exceptions. And I won't go into a lot of detail, but I leave this slide in here as a reference because truly when you start to see your performance rates, and you may have done chart review in the past, or maybe you did measure groups in the past, your performance rate may not be the same if you now choose to do ECQMs or Registry, and it's a good idea to have understanding of these calculations so you understand where your performance and your reporting rates are coming from. Similarly, on this next slide, I leave an example in here for anybody for reference to go back. This is an example of a fall risk assessment with some fake information about and how you would actually calculate the data completeness rate and the performance rate. So please feel free to kind of go back and take a look at these as specific examples of what is a denominator exclusion or what would count as a denominator exception. Okay. Another thing to keep in mind is that CMS, before they'll even score your quality measure against the benchmarks, requires you to meet some minimum criteria. So there's two types of measures really for Mips. There's ones that will be able to be scored based on the performance, and there's ones that won't be able to be scored on performance because they fail to meet one or more of these criteria. So these criteria are that they have to have, the measure has to have a benchmark, there have to at least be 20 cases in the denominator, that 50% data completeness rate, and the performance rate is greater than 0%. So if it comes back and you only are generating 3 points for a measure, it's likely that you missed on some of this minimum criteria. You have to have all 4 of these criteria met before you can earn up greater than 3 points, before you can actually start getting scored against that CMS benchmark decile. So on the next slide, if you do meet all those 4 minimum criteria at a measure level, then your performance then gets compared to what is being called these CMS benchmark deciles. So towards the end of 2016, CMS published a spreadsheet with all historical information from actual PQRS results and actual CAPS results, and they show for every single measure how many points you would earn for each of the deciles. And so an example here on the next slide is, let's say you are submitting data for the influenza immunization measure, and you scored a 35% for that measure. Well, these are the published deciles for the influenza immunization registry measure, and a 35% performance rate would correspond to this 5th decile. And so you know that you would earn between 5 and 5.9 points if that was your performance rate. And it's definitely a sliding scale. So you're competing on everybody else who is submitting data on this specific measure, and not until everyone's data is tabulated would you know that you earned 5.1 or 5.5 or 5.9. These are the deciles, though, that will increase year after year as overall performance for this measure increases. So maybe a 35% for this measure gets you to decile 5 for 2017. It might only get you to decile 4 in 2018. So again, keep in mind that the Mips quality scoring is competitive and is competitive against everyone else that's submitting the same. You can find all there on the resources section on the QPP website, and I put the link there. All right, so here's the example from the final ruling. It's table 20 that's in the final ruling that has a hypothetical set of 6 measures that get scored, and here's the points based on performance. Here's the total possible points, and it just illustrates how you can start to count up the different bonus points. Again, 2 points for each additional outcome measure, 1 point for each additional high priority measure, the additional bonus points that you get for end-to-end reporting because you use data coming out of your certified technology, and then also keep in mind that those bonus points are capped. And so in this specific example, when you add the performance and all the bonus, they get the total 60 out of 60 possible points in this quality performance category. So for this example, if this was what you had submitted and you generated 60 total points when you counted up all your points from performance as well as all your points from bonus, and since 60 is the total max, that's basically you got 100% for this quality performance category. And the way that this would be scored, though, in the final Mips composite score is that since you got 60 out of 60, this total quality performance category score would be 100%, because 60 out of 60 obviously is 100%. That would be multiplied by the weight of that category, which is 60 points, and you would get all 60 points towards your Mips composite score. So that is a perfect example, obviously, and you are just 10 points then shy of reaching that exceptional performance threshold at 70 points or greater. So that's why it's so important for you to understand how you can generate performance points in the quality category, because so much of it actually can contribute to that total composite score of 100. Okay, the next largest category for Mips for this transition year is the Advancing Care Information category. So again, this is what has replaced the Medicare EHR incentive program, otherwise known as Medicare Meaningful Use. It's weighted at 25%, or also meaning that you could generate up to 25 points out of your total 100 points could come from this category. Just keep in mind that this did not impact Medicaid Meaningful Use or the ones for hospitals. So, of course, Medicaid Meaningful Use, which is administered by state Medicaid programs, you could still have to do attestations and things if you still do Medicaid Meaningful Use. But this has replaced the Medicare Meaningful Use program, and so there's no more Medicare Meaningful Use, there's no more CQM requirements through Medicare Meaningful Use. All that has been converted into Mips. For this first transition year, there are 2 measure set options, and they did this, of course, because you don't need 2015 edition certification of your EHR until 2018. So they basically allowed 2 different measure sets. One's called, ACI Objectives and Measures, and that's what's aligned to the newer edition cert. There are 5 base measures, and one has the same thing, but it has the word transition in it, and that's aligned to 2014, in which there's 4 base measures. The scoring for Advancing Care Information comes from 3 different buckets. So you can earn up to 50% of the total ACI score from your base score. And if you do not participate in the base score at all, you get a 0 for the category. So it's not like you can just do the other objectives and measures that are part of the performance. You must meet the base score at a minimum. But the base score is not that difficult for this year. You either have to submit the 4 or 5 base measures, depending on your cert edition. And these 4 or 5 base measures, one of them is a yes-no attestation. It's a security risk analysis. And the other 4 measures, or 3 measures, only require a numerator and denominator on 1 patient. And if you are reporting as a group, that's 1 patient for your entire group. So it should be fairly easy to be able to earn that base score. The largest portion, though, that could be influenced in your Advancing Care Information points is the performance-based. And so here there are another 9 objectives and measures that are available in this measure set according to 2015 cert, or there's another 7 objectives and measures that are available in this measure set. And for each of those, the numerator and denominator then generates a performance score, and based on that performance score, each measure is worth between 10 or 20%. And so, for example, if you generated a 70% performance rate on a measure, it would earn you 7%. And then the third bucket is bonus score. And so you can earn up to another 15% of your total ACI score for things like sending data to a specialized registry or a public health registry. And there's also a list of improvement activities in which you use CERT that can also generate 10% bonus for you. The other thing regarding this category is that they understand that, of course, not everybody has control or influence over the EHR and certification of their EHR, so CMS does offer flexibility in which they re-weight this category to 0 and put it into the quality category for certain groups like non-face-to-face providers, mid-levels. You can ask for kind of a waiver if you kind of lack any control over the technology decisions, and then also hospital-based providers. Now, again, once you have the base score, the performance score, and the bonus score, and again, the 50 and up to 90% or up to 15% are the weight of the total ACI performance score, you can generate actually more than 100% in your total advancing care information score, but it's capped at 100. And so if you earn 100 or more percent, so it's 100 points out of a total 100 points, you're going to receive the total 25 points, which is, again, the 25% weight of the Mips composite score that comes from ACI. So, again, if this was 100%, you could generate 100% times those 25 points, and then you could add that to your Mips composite score. And then the third category for this transition year is coming from improvement activities. And so again, this is the new category. These are about 92 different activities that really are helping transform practices from, fee-for-service and volume into value-based care. There's no performance rates. They're all yes-no format. There's no bonus opportunity. The only thing with the scoring here is that they're high-weighted activities and medium-weighted activities that are worth a different amount of points, and you're trying to earn a total of 40 points. And again, like I mentioned with ACI, there are some activities that can earn you bonuses in the advancing care information category. A couple high-weight examples include that CAPS that I had mentioned, so doing a patient stat survey, and also if you participate in a transforming clinical practice initiative like a practice transformation network, that also is already a high-weighted example. And then similar to ACI, there's different levels of participation and some flexibility. And so if you're in a small group or rural or healthcare shortage area, then you really only need to generate 20 points. It's basically the activities are worth double than what they are. And then if you're in a patient-centered medical home or you're in a Medicare shared savings program track 1, you're automatically earning full credit for this improvement activities. So those are the three categories again. So again, quality category, if you got the 60 out of 60, that's 100%, you would get all 60 points. ACI category, if you generated 100 or more percent, you got all 25 of those points. And improvement activities, if you generated all 40 out of the total possible 40 points, you would get all 15 of those to generate your total Mips composite score. All right. So I'm going to change a little bit just to make sure that there is some knowledge, kind of information about selecting Mips measures. And so a lot of this is for reference, and if you haven't put together a strategy, these are just really some tips to start thinking now. Again, it's not too late about really how to optimize. So a couple of tips here. Sorry about that, are to, look at previous quality resource and use reports from PQRS. Take a look at the QPP website to understand the measures out there. There's a couple, important factors also about how to pick your measures, if the types of conditions you're treating, the type of care, the settings, as well as your other organization's quality improvement goals. So a lot of the Mips measures overlap with HEDIS or other pay-for-performance measures that your commercial payers want. So like if you were to improve breast cancer screening or colorectal cancer screening or controlling high blood pressure, more than likely those are also on your commercial payers list also. And then, of course, the most important thing is aligning your measure specifications with your data collection. So your EHR workflows, your code capture, that all gets into the richness of the data that is able to be used to calculate your measures. Here again is just a link for taking a look at all the quality measures on the QPP website. If you have not been on that website recently, they are getting all fancy with changing colors and changing navigation, really. But they do post periodic new updates, and so they're trying their best to be responsive to the sea of confusion out there and to provide good resources. So I recommend you going onto the site. A couple other suggestions, since you do have to have an outcome or high priority measure, outcome measures are pretty hard to come by. A lot of them are surgical and based. 3 that I would recommend looking at, though, that are high priority and that are primary care in nature are care plan, controlling high blood pressure, and documentation of current medications in the medical record. So all of these are high priority and would cross that requirement off your list. And there's things that are not that difficult or you might already be doing in your workflow. So I strongly suggest if you haven't at all started to narrow down your list, you could start with these specifically for primary care. Some other examples to share: if you were doing the annual wellness visit on your Medicare patients every year, there are a lot of requirements within the annual wellness visit that need to be done that are mandatory, that are just part of the intake and the curriculum of an annual wellness visit. And you may be doing all of these things already, and these are all tied to registry measures. So all of these measures, and we actually put the quality data codes in here for how you get credit. You could work with your EHR vendor to make sure that your workflow is capturing these in a discrete manner. If they're not putting the quality data codes in there, that at least there's a way to kind of discreetly capture that you're getting credit for these. So there's a lot of measures that actually can be done at every annual wellness visit. And then a couple other things to keep in mind with measure selection is that there are, some measures that have follow-up requirements that you can't get credit for it unless you do both the follow-up as well as the screening. Some of them have multiple components to meet, like the screening for alcohol misuse. You have to do the counseling if you find that the person has alcohol misuse problem. Some of them have specific documented assessments, like the depression screening for PHQ-9. You can't do the PHQ-2. You can't just do the first 2 questions. You have to have documented all 9 questions were done. So just things to keep in mind when you're taking a look at measure considerations, because these all will affect workflow and, of course, take time during the office visit. All right. So just a reminder of the different data submission methods for groups. Administrative claims, obviously, that's just the only measure available is the 30-day all-cause hospital readmission. A CSV file gets what's submitted by CAPS vendors, if you're doing CAPS for Mips. The CMS web interface, again, is the online portal to be able to input. But the ones to keep in mind here are claims registry, which use both quality data codes, or you need to have kind of discrete kind of measurement and capture in your EHR, or if you do ECQMs, electronic clinical quality measures. And so these are going to be all strictly codified data, like SNOMED codes, RX norm codes, LOINC codes. And so it's very strict measure specification for looking for codes to be able to capture those measures. These are, again, some just helpful tools and resources that I mentioned, how for things like CAPS or CMS web interface, the measure specifications, the benchmarks. Again, I definitely encourage you to visit that QPP website. They have a lot of resources on there and guidance. And since it's a transition year, they keep on adding new information as well. Okay. And the last couple of slides here before we get into the demo, I wanted to just kind of clarify what a qualified clinical data registry is. So QCDRs actually came about, I think around 2014 or so, as a different way to submit PQRS, actually. And so they're like a registry in which they're a CMS-approved entity that collects clinical data on behalf of clinicians for data submission. But they differ from a qualified registry because they aren't limited to measures within the QPP. And so a QCDR can report or host or create actually non-MIPS measures, which then can be also used for MIPS, and so that's one of the differences. CMS is also encouraging the use of QCDRs to support value-based care initiatives. So they're really looking for QCDRs to be that kind of population health registry, that backbone. And that's why there's so many QCDRs that are tied to improvement activities. And so there's a lot of encouragement for CMS to have improvement activities carried out through QCDRs. And then, there are a lot of validation steps that are required of a QCDR. There's just a lot of validation of TINs and NPIs and reporting methodology. A random audit has to be done. Feedback has to be given regularly to the client. Validation reports need to be submitted to CMS. So to be a QCDR, there are extra kind of steps that have to be done to maintain that certification, which is important for data integrity and accuracy. And so lastly here, just to kind of keep in mind for, what type of technology tools are out there to help you maximize MIPS, and maybe what you might need to be able to proactively drill down and improve certain measures. And so some of the features of SPH's QCDR product, for one, it's a huge advantage to be able to pull data from multiple EMR systems, as most health organizations are not on a single EMR. And so now you have a complete picture of performance across different providers and patient populations. You want the ability to be able to drill down from a network to a TIN level, and from a provider to a patient level. A couple other things about the QCDR application that has been developed by SPH that you'll see in the demo shortly is that we take some of the thinking about the regulations away that you don't have to deal with. So the minimum requirements of the measure that I was talking about earlier, like you have to have a benchmark and you have to have a minimum case denominator, those will be flagged in our application, as well as an automatic calculation of the top 6 measures. And then, of course, to be able to drill down to look at the measure performance to see those numerators and the denominators and what's really driving the performance. And then really to have a tool that, in near real time, almost you can see that data that was captured in EHR reflected into how it would impact your MIPS performance. So I think those are some of the kind of key features that we'll go ahead and share now in the demo. So, Terry, I'm going to send it back to you.
Thank you, Sara. Next, I'd like to introduce the person who will be doing the demo as our next speaker. It's Laurel Borowski. Laurel is the clinical product owner over the QCDR Plus Medicare MIPS product. Prior to SPHA, she served as the Solution Director for Clinical Analytics at Streamline Health and worked at the National Cancer Institute in Outcome Research. She has over 10 years of experience in quality measurement, clinical analytics, and population health. Laurel holds a master's degree in public health and epidemiology from The Ohio State University and a bachelor's in zoology and microbiology from Miami University of Ohio. Welcome, Laurel.
Okay, thanks, Terry. What I'm going to show today is our QCDR Plus Medicare module. And so right now what we're viewing is our network summary level. So I'm coming in as Elizabeth Blackwell, the Director of Quality for Atlanta Health Systems. Here she can see all of her 24 practices and at a high level how they're doing on their quality point range. You can see how many MIPS eligible providers there are in each of the practices, how many patients there are in each of the practices, which would impact the payment that you may be receiving on your Medicare Part B payments. And then those practices that are meeting MIPS requirements and those that aren't. So easily you can sort to see those practices that might need to improve their score and those that are bringing in the highest point range for your network. If we drill down to the practice level or the TIN level, you can see all of the measures that TIN is reporting on. You can see the measures that are meeting your practice's benchmark level and those that are not, and those that are meeting the reporting rate of over 50% or not. And as Sara mentioned, here's our SPH algorithm that calculates your top 6 measures. We show the percentage that you get on each of the measures and how it aligns with the CMS benchmark. So if we go to this measure, influenza immunization, we can see that the 60.3% falls into the 7th decile and earns 7 to 7.9 points for this particular measure. In addition, we provided a calculation for the number of patients that you need to impact in order to move to the next decile. So in order to get 8 points on this measure, you have to impact 3 more patients for influenza screening for the particular measure. Additionally, we point out if a measure is not eligible for MIPS. So for fall screening for future fall risk, this measure is not meeting that particular rate because of the reporting rate. The reporting rate is less than 50%. That was one of the 4 key criteria that is needed in order to submit for MIPS measure. So because we want to drive quality improvement, we also show all of the other measures that are being calculated for Centerville primary care. So at the practice level, we see 12 of the measures that are being calculated. You can drill down to see the specific performance rate, your particular QCR benchmark, how the performance rate is varying from the benchmark, the reporting rate, and then the specifics of the measure, as Sarah pointed out earlier. Do you see the number of patients that have met the measure or not met the measure, and all of the patients that are in the denominator of the measure? We also show this information in a graphical format. This can be exported into Excel and also used for quality improvement. As you expand the measure, you get to see the description and the quality ID. We also point out which of the measures are high priority and outcome, because it is important to track those high priority and outcomes for your bonus payments. As we drill through on the colorectal cancer screening measure, you can see all the patients that maybe are not meeting performance, because you want to improve the score on this measure. When you drill through, this will take you to your patient screen. So here are the 19 patients that are not meeting the colorectal cancer screening measure. In addition, we show all the other measures that they're not meeting. You can use this screen as a care management workflow, bring these patients in, and close the care gaps that are required for the Mips measures. Provide all the patient demographic information and then also the patient follow-up information in order to get those patients in. And this can also be exported to Excel in order to drive care management. If you clear the filter, you see all of your 1,038 patients that are eligible for Mips measures within Centerville Primary Care. So this gives you a holistic view of all of your patients with all of the open care gaps. That was a quick overview of our Medicare module. Additionally, we have a provider scorecard that will show all of your providers and how they are lining up for each of the different measures. So for this view, we have 10 providers, all of the patients that are eligible for the measures, the total measures that the provider is eligible for, and those that are meeting benchmark or below benchmark. You can quickly see across your practice how many providers are doing well on your Mips measures and those that need some improvement. Additionally, we're working on a commercial module, which will take into account other quality measures across your commercial payers. Because we want to impact all of our measures in one place, this module shows you all of your quality measures for your commercial payers. We're going to be doing a demo of that in the next couple weeks. If you're interested in the commercial module, please stay tuned. All right, Terry, that's all I have for now.
Thank you so much, Laurel. We will now open the presentation up to questions. I have a couple, actually, that were submitted while the presentation was going on, but if anyone else would like to submit a question, please do type it into the Q&A tab of the WebEx portal now, and we will do our best to get to all of them during the remaining time. The first question I have is, do we need to register if reporting by a group?
I'll take that, Terry. This is Sarah again. So registration by June 30th, so that's the end of this month, is only necessary if, again, your group is participating in Mips via the CMS web interface, or you are electing to administer a CAPS for Mips survey. And if you actually were a group that registered for GPRO web interface in 2016, you actually are automatically registered already to use the CMS web interface in 2017 for Mips. But if you want to choose a different data submission method, then you should cancel your election by the end of this month, by June 30th. However, if you did CAPS for PQRS in the past, you were not automatically registered to administer CAPS for Mips, so that one you will have to go ahead and re-register. If you are a group that participates in a shared savings program, then you don't have to register. So this is really only for non-shared savings Mips providers, groups.
Thank you, Sarah. Next question. How will improvement activities be validated by CMS?
So, as you know, CMS audits things, just like they audit meaningful use. And so in the final ruling, CMS, it was stated that CMS has to provide criteria that they use to audit and validate measures and activities for the transition year of MIPS for the 3 categories. So just a couple of months ago, on April 26th, CMS actually published this validation criteria for the 92 improvement activities. So it is in the resources section on the QPP website, and there's a big spreadsheet there that you can download that lists the suggested documentation that you should have for each of the improvement activities. Again, because those are those yes-no activities. There's no really data to submit. There's no scoring. It's just that whether you're doing them or not. But they do give suggested documentation on the QPP website.
Great. Next question. This one came in actually with registration. Someone asked, what are the implications of group versus individual reporting?
Okay, so one of the main things is that all the NPIs under the same group TIN would receive the same MIPS composite score, as well as each of the category scores. And so that's one of the key benefits, specifically when you are have a group with specialists, and so maybe the specialist would benefit by getting rolled up into the group, because then you would have the PCPs that may have more control over measures, and the specialist would kind of just get the benefits of that and would get the same MIPS composite score. So that could be definitely an advantage. If the provider works and bills Medicare through different MIPS eligible groups, then they may receive more than one MIPS composite score, and all of them actually would be published on Physician Compare. So you could have more than one MIPS composite score reported for you if you were a provider that worked in different clinics with different billing TINs and they were all MIPS eligible. A couple other things for groups, of course, they have a couple of more ways to submit data. You can do CAPS for MIPS if you are 2 or more providers, and then you can also do the CMS web interface. And so those 2 data submission methods for MIPS are really only available for groups. And then just keep in mind that the payment adjustments follow the NPI-TIN combination. So again, if you were a provider that worked for multiple clinics or that billed under different TINs, it's very possible that you could get a positive adjustment for one group and a negative for another and a neutral for another, because it is following the NPI-TIN combination. Okay?
Great. Thank you, Sara. Next question. We are a small practice with under 6 providers. How are the regulations different for small practices?
Okay. So CMS actually defines small practices as those with 15 or fewer clinicians. So definitely a 6 and under would qualify for that small practice. So there are a couple of, slight differences in the regulations, but then also some, things that CMS has really pointed out. Of course, that low volume threshold exclusion might kind of impact certain small groups where there's, you'd be MIPS exempt if you billed less than or equal to $30,000 in Medicare Part B allowed charges, or you saw less than 100 Medicare patients. I think probably the biggest thing, though, to keep in mind is that reduced requirement for improvement activities that I mentioned. So it's really only 1 high-weighted activity or 2 medium-weighted activities. So instead of really needing the 40 points, you would just need the 20 points. And then there's also a lot of really support. So MACRA is also providing, $20 million each year for 5 years to fund training and education for Medicare clinicians in individual or small group practices, that are working in underserved areas. And then, there's also increased ability for clinicians practicing at critical access hospitals and rural health clinics and federally qualified health centers to qualify them to get into the kind of the next more advanced phase, the other track of QPP, which is the advanced alternative payment model, so to become a qualified participant. So those are just some of the things supporting the small practices.
Great. I want to make a comment. I've gotten 2 questions about whether people can get the slides for this presentation. We will make the slide deck and the recording available. We'll email that to all attendees within a couple days following the webinar. Next question. If you choose to submit as a group not through web interface, does the performance of all providers get aggregated so that in your example, the specialist non-performance would dilute the primary care performance?
Can you repeat that again? So if you submit by CMS web interface.
That's correct. If you choose to submit as a group but not through the web interface.
Oh, not through web. Okay, not through web interface.
Does the performance of all providers get aggregated so that in your example, the specialist non-performance would dilute the primary care performance?
So it depends on the measure, of course. So it's the patients that belong to the eligible denominator, right? So if you think about a primary care provider who sees a lot of diabetic patients, and then you see a dermatologist, that dermatologist might not have any patients that are eligible in certain measures that a primary care provider. So it's not that your providers dilute each other, it's a type of patient. So it's very possible, I'll give you an example where it could dilute. So you could have specialists that there are certain, and you choose certain measures that they don't require any diagnosis code, right? So like care plan. A care plan could be done at, every year during an eligible visit that happens during the performance year. You don't need a qualifying diagnosis code, and so you would have a lot of people eligible for that measure. But in the course of kind of practice, you don't have a lot of maybe specialists asking those questions about care plan. So they might end up supplying a lot of eligible cases, but then didn't influence the performance being met. So in that situation, you would have those specialists maybe bring down the performance of that measure. So it really is a measure by measure. So here's another, on the reverse side, maybe you have a handful of ophthalmologists that do very great performance for certain measures, and you want to include them in your MIPS. If those measures are for very narrow populations that wouldn't necessarily be seen by your primary care providers, they might be beneficial to you. So maybe they are very specific to post-surgery, post-cataract surgery or something like that, and they do very well for them. You actually then could have the primary care providers reap the benefits of those ophthalmologists scoring very well on those specialty measures. So it's not so much a specialty versus primary care issue, it's a measure by measure and who is in that eligible patient denominator.
Great. Thank you, Sarah. Next question. Since MIPS replaces PQRS, MU, et cetera, will provider organizations still have to complete medical attestations?
So again, the attestations in the past were for Medicare meaningful use, right, or Medicaid meaningful use. So for Medicare meaningful use, of course, there's no more attestations for Medicare meaningful use, but attestation is a legitimate data submission type for the advancing care information category. And so you still may have to do attestations for Medicaid or hospital program meaningful use, but any attestations that you did similarly for Medicare meaningful use would be towards the advancing care information category. And so that advancing care information category, again, has replaced Medicare meaningful use, and you could have data submitted, through a QCDR, through a registry. Attestation is still one of the options to submit data for the ACI category.
Great. Thank you, Sarah. That's all the questions that I have lined up. I'd like to thank Dr. Bill O'Connor, Sara Zywicki, and Laurel Borowski for this enlightening presentation today about taking action now to maximize 2017 MIPS scores. As a reminder, we will email the slide deck from today's presentation, as well as a link to the webinar recording to all of our attendees within the next couple of days. I'd also like to let you know about an upcoming webinar.
Oh.
Next slide. slide. Thank you. It's called Maximizing Commercial Payer Incentives by Closing Care Gaps. It will be on Thursday, June 29th at 1 o'clock. We're excited that the webinar will feature Susan Helton, who is Executive Director of DeKalb PHO, and Sara Zywicki, whom you heard today. You can see the topics on the slide. Note that Laurel mentioned during her demo, she opened briefly the module that addresses commercial payer plans, and so that will also, there'll be a short demonstration at the end of the webinar where you'll learn more about that particular module. With that, I'd like to thank all of you for joining us today, and I hope you will join us for future SPHA webinars, and we hope all of you have a great day. Thank you again to our presenters.